Hello everyone, welcome to my presentation. My name is Hamideh Toudeshky and I study in Computer Science Department. Today I'm excited to present our work entitled Evaluating the Impact of Immersiveness in Virtual Reality Simulations on Anxiety Reduction for MRI Procedures. MRI is a non-invasive imaging technique that provides 3D internal images of your body, especially soft tissues, for diagnosis, treatment, and disease monitoring, such as in cancer. The studies show that medical imaging anxiety, including MRI-related anxiety, affects 49 to 95% of patients due to factors such as enclosed space, like inside the bore, loud noises, and the need to remain still. This anxiety can lead to appointment cancellation, early termination of scans, using sedation with the side effects that they have, like allergic reactions and poor image quality due to patient movement. As a result, repeated scans may be necessary, increasing the overall healthcare burden. Virtual reality exposure therapy is a promising solution and a type of exposure therapy in which individuals confront and manage their anxiety in a safe and controlled environment. Since everything is virtual, it is a cost-effective solution for reducing MRI anxiety. The main gap here is whether anxiety reduction here is due to the immersive nature of virtual reality or the habituation that happened. In this study, we aim to investigate the relationship between different levels of immersion, physiological responses, including heart rate, skin temperature, and electrodermal activity, and anxiety reduction in the context of VR-based MRI preparation. Optimizing virtual reality exposure therapy can enhance its effectiveness and accessibility, catering to diverse needs of patients with varying levels of anxiety. Here are our hypotheses. Hypothesis 1 has three subsets. Participants will exhibit an increased heart rate, elevated electrodermal activity, and skin temperature change during the immersive experience rather than when watching the 2D or 360-degree video. Hypothesis 2, participants with moderate to high anxiety before the experience will have lower anxiety afterwards, regardless of the order of scenarios they experience. Hypothesis 3, participants will feel more immersed in the immersive VR experience than in other scenarios. Here is our solution. We developed a VR application with three different levels of immersion. In the top image, you can see our waiting room, where each individual can choose which level of immersion they want to experience. From left to right, the first option is the 2D video, where participants watch a standard video about the MRI procedures. Next is the 360-degree video, which offers a more interactive video experience. Finally, the immersive VR scenario allows full interaction. For example, a head coil placed on their head when they feel like they are lying on the MRI bed. Additionally, they can see other elements such as the control room window. For anxiety measurement, we use both physiological data and self-reported anxiety. In this image, you can see the emotive sensor, which we use to collect physiological data. We measure heart rate and skin temperature, capturing temperatures variation linked to emotional responses. Additionally, we collect electrodermal activity data, which reflects change in skin conductance. For our user study, we had 13 participants, and the procedure followed the flowchart shown here. Each participant experienced all three VR scenarios in a randomized order. Physiological responses were measured during each scenario. Participants also feel self-reported anxiety at multiple points before the experiment, after each scenario within the VR application, and after the study. Additionally, they completed an iGroup questionnaire for measuring presence for each scenario. Our results for hypothesis 1 were mixed. We did not observe a significant increase in heart rate between scenarios. However, trend lines indicate that the maximum heart rate was highest in the immersive VR scenario. The effect size was medium for comparison between 2D 360-degree video and immersive VR scenario. For electrodermal activity, we did not observe a significant difference or increase between scenario. However, trend line shows that for maximum EDA was moderate in the 2D video, variable in 360-degree video, and highest in immersive VR. Additionally, for maximum EDA, the effect size was medium when comparing the 360-degree video to immersive VR. For skin temperature, we did not observe a significant change either. However, trend line indicates that the 360-degree video scenario had the lowest average temperature compared to immersive VR and 2D video. The effect size was low across all of the scenario comparisons. The results for the VAS questionnaire were significant. We found a significant difference in anxiety levels. For participants with moderate to high anxiety before the experience, there was a significant reduction in anxiety after the study. Regarding the IPQ questionnaire, which consists of 4 subsections, we did not find any significant differences in spatial presence, realism, or involvement. However, for general presence, we observed a significant difference. So we can say that this hypothesis was not supported. Trend lines indicate that as immersion increased from least immersive scenario to the most immersive one, participants reported a higher sense of general presence. Interestingly, the sense of realism in the 360-degree video was higher compared to immersive VR. According to participants' feedback, this was due to the higher resolution and the detail elements present in the environment. So we conclude that there is no one-size-fits-all solution for virtual reality exposure therapy in MRI-related anxiety. And personalization is essential as participants exhibit variability in both physiological and subjective responses across immersive scenarios. To ensure effective therapy, the VR experience should be customized based on individual anxiety levels and specific needs. For future work, we plan to conduct a larger study with a more diverse participant pool to further validate our findings. The median effect size observed for maximum EDA and maximum heart rate that we mentioned before in this preliminary study suggests valuable insight for future research. Additionally, we want to incorporate realistic sensory elements to enhance immersion. We want to investigate repeated VR exposure to understand habituation effects. And we want to explore real-time biofeedback to dynamically adjust VR exposure based on physiological response. Thank you so much for your attention and have a good day.